All right. Thank you, Bobby. And thank you to Innovasis again for a great meeting, great place to be. And it's a wonderful, wonderful location. I think my wife loves this place. That's one of my neurosurgery buddies from Baton Rouge, so Chuck Bowie. So obviously, I mean, the lateral approach is not as familiar as open posterior or posterior approaches for most folks. And so it's something that's always going to be learned, like most things, but you're going to have to take a jump to where you feel comfortable to be able to do these things. And there's a lot of steps that go into that to be able to do safe surgery and get good outcomes for our patients. So obviously the rationale, I mean, Tony did a lot of speaking about this. It just depends compared to what the other procedures are and really what your goals are, but it's quite a good alternative. And whether it's being done minimally invasive from the back or open from the back, just depends on what the diagnosis is and what you're really trying to achieve. We all know the different possibilities for really any interbody reconstruction, whether it's done from an open, posterior, anterior, however you want to do it. There's a lot of options. So you really have to decide. I think that you have to look at that pre-op. The pre-op imaging is really the key. And when you're especially looking for lateral, you just can't look at it and say, oh, it's a spondy on the X-ray. Oh, it's bad stenosis. It's a disc, whatever it is. I mean, you've got to really be paying attention to these things, much like our vascular surgery colleagues or our general surgery colleagues. And it's just, there's more to it. And a lot of thought has to go into it. Now, as far as the things that I've used it for, I mean, you can really use lateral for a bunch of different things, because I think really the bottom of this slide, I mean, it does really give you an opportunity to get a very high fusion rate with avoiding a lot of the problems associated with anterior approaches, and particularly in obese patients. It's a game changer compared to someone that you just can't do an ALIF on. Obviously, at 5'1", it's a problem. So I won't spend too much time on this, but also, in addition to looking at the crest, you're going to be looking at ribs, and you're going to be, especially in the scoliosis patients. Another thing to look at is how much rotation you really do have, because the concavity is almost always where the rotation is rotating anteriorly, and so if you're getting that on the right side, if the ribs and the liver are getting in the way, I mean, you can have a lot of issues there that you just have to pay attention to all these issues. I think planning is the key. I do think a huge anterior psoas at 4-5, and especially looking at where the vessels are on the imaging, is just so important, because we're not vascular surgeons. And so let's just be honest, that's the whole point of this talk, is avoiding the nightmare. And if you're doing this and you don't have a vascular surgeon there, you're going to have a massive problem. And fortunately, I've never hit the vena cava or the aorta. We've had colleagues in our area that have, and they've expired. And it's just, and that's even with vascular surgeons in the area. I mean, it's a horrible, terrible problem. And so you just got to really be thoughtful with what you're doing with these things. And so, as we talked about before, just going through thinking about it, we've already done these things as far as the indications, how you go about deciding which side. And I mean, I've definitely been the table. I think that, one of my old colleagues in fellowship at Jefferson, Greg Anderson, never bent the table. He always just put him on a flat Jackson, and somehow, but Anderson's a wizard, and he can do, a 3-level lateral on a flat Jackson and get it done. But in my hands, that's just not something that is quite easy to do. It's the difference between being able to get 1 cage versus really safely and easily get 3 cages a lot of times for a case such as this. So different cases, we've already gone over this. I won't harp on this as far as how you want to go about doing these cases. And we've already gone through a lot of the positioning techniques, but sometimes you can have complications from this with the positioning. You know, always, but you do have to directly take the skin. Absolutely, you have to directly take the skin. So a lot of times nurses will want you to not do that, or they want to put something over the skin, but in particularly in more obese patients that have soft fat and they're easily going to roll, it's a big problem. So, you know, you just don't want anything to change where you think those vessels are, because that's the biggest problem for us, is in a problem that we can't really fix on our own. So different ways to do this. Make sure you get good X-rays. I mean, once again, about the vessels, but you can't trust your MRI axial images unless you know you have a true AP. The true AP has to be adjusted at every single level. So every time you go to the next level, you need to make sure that you have a perfect X-ray. And that's pretty much initially right after you start. I mean, the guide wire can go in, but as soon as the cob's going in, and especially if you're going to the contralateral side, as you saw, you know, the vena cava and especially the right common iliac definitely tucks, far more common on the right side than on the left. And so you really have to pay attention. You're like, oh, I'm going on the left side, I'm safe. But like you said, Tony said, you can definitely be very close to that cob. I'll always angle that cob posteriorly a bit to go on and pop through contralaterally, but definitely be very careful anteriorly. So sometimes I used to do 2 C-arms, but now I've just gone to 1. It's just too much of a pain, and you know, just now I've gotten more facile with just doing it with 1 all the time. We won't go through all the different technique. I think that's different here, but I mean, this is the kind of patient that, you know, it's just a nightmare. I mean, for an open posterior or an anterior approach, this is like, I mean, just an absolute nightmare. But what do you do with some of these folks that are, I mean, it's difficult. You try to get them to lose weight. You try to get them to go see if they're bariatric. I mean, it's difficult. And so you don't want to do an open procedure on this where your risk is too high and the patient's risk for a complication is too high. Nerve avoidance. So early on, I mean, I think that, well, let me just say this. I think the biggest things are understanding your level, understanding whether or not you have a Mickey Mouse sign, being able to get a level done less than 20 minutes, but definitely less than 25. And it's difficult when you have a hard 4-5. Let's say you have a pseudo from a posterior approach. You can't do an anterior approach. You're trying to get a cage out at the same time. You got a crest in the way. There are a lot of issues. And there's only a lateral to really get this done. So what are you going to do? I mean, so it can take more than 20 to 25 minutes. But try to get that done quickly. And I do admit, I do monitor with motor now when I do 4-5. And a lot of times at 3-4, 2-3, if there's not a medical contraindication to it. But using motors has really changed the game as far as being able to do 4-5 levels, and I feel to being able to do it more safely and to really trust the monitoring. Another thing is I've just gone to a direct open look. I'll look at look directly at the disc space. So there's not any trusting the monitoring as I traverse the psoas and whether I'm trusting this needle placement. I'll still stem when I get down there, but on the way down, I'm looking at it directly. So I use 2 renal vein retractors and then just you incise the fascia, split it, spread it, go up and down, work your way through the psoas carefully. You're watching the whole time. You'll see nerves. Don't get scared about it. Nerves don't scare me. Vessels scare me. So, but this is early on. I mean, and I think it's just retractor time and not doing a direct open look. And this was even with using some motors. But if you spend a lot of time in there, then you're going to have changes. And, you know, femoral nerve problems are a nightmare. You know, I never did the 2-incision technique. I think that some people do, but I think it's just easy enough to just do the 1 incision. As soon as you learn it and you've gotten somebody to teach it to you, then it's very easy to be able to just visualize all these different structures and prevent.
Routinely do the 2-incision?
Yeah. Yep. I think as soon as you start doing a few of these, you're going to realize not that much of a value. So all the different structures are there. I mean, the ureter, I've never had a problem with the ureter. You'll see the genitofemoral nerve quite a bit. I think the real thing is that you will have people that will have still some muscle soreness, and just counseling them appropriately beforehand on what to expect is really the important thing to do there. So I'm going to fly through these. These are just different cases. And, you know, like Tony had said before, you can always go a little bit more anterior, but I think with a number of these different pearls that we've said, you can do these things without getting too much complication at non-4-5 levels for sure. And then with the retractors, I mean, open it as little as you have to. I mean, I always stem where the pins are going to go. I want the pins to stem greater than 8 if at all possible. And if not, I'll just put a unilateral pin in and not put pins on both sides. But having the ability to know that the retractor is not going to walk on you, it's not going to move, is huge. And then you can trust where your trials are going to go. I think wide implants prevent subsidence, increase fusion rates. I'm a huge fan of them. So I think that there's no doubt that that's possible. Even 26s are potentially ideal in some patients. You got to obviously know who's got osteoporosis, know how much correction to go for, be careful with it, and just understand the overall situation. Corpectomy pearls, I mean, it's a more complicated problem. It's higher up oftentimes. I mean, there's a lot more structures to think about, but these can still be done safely. And you know, I'll have my vascular surgeon, you know, a lot of times I'll do it, but I'll have him in there when I'm doing a corpectomy. And I know that, you know, I'm going to be right there by the vessels. You're going to have to deal with them. But it can be done well, and still have overall good outcomes. So I'm going to let the rest of Steve come on up here and not keep everybody too long. Here's a few pearls. Thanks, guys.